Started. Okay. So today our presenter is going to be Jan. Jan, you can go ahead and start introducing yourself and get started.
Yeah, thank you so much. So good afternoon, everyone. Let me just move this around. Okay. Okay. Good afternoon, everyone. I hope you guys are having a great weekend. So my name is Jan. I'm a fourth-year medical student from UMHS. And today I will be talking to you guys about the role of aromatase inhibitors in hormone-positive breast cancers and their benefits in extending their treatments. Okay. Oh, thank you. So why I chose this topic? So besides my interest in oncology, this month is Breast Cancer Awareness Month. So I thought it was just a perfect fit for this month's meeting. So for a little bit of background, breast cancer is the most commonly diagnosed cancer in women worldwide, and it is the leading cause of death from cancer in women. As for the CDC, the last statistics they have is in 2021, more than 270,000 cases were reported, and the following year with more than 40,000 deaths. In addition, cancer has like a 5-year survival rate, which decreases as the disease spreads. For example, if the disease is localized, it has around like 98% of survival rate. Whereas if the disease is distant, it has around 31% of a 5-year survival rate. So very concerning. And this is one of the reasons I also chose this topic. Oh, so this so my topic today is gonna focus be management side of the cancer, specifically the hormonal options. So cancer basically, or breast cancer treatment is highly dependent on 3 factors. One of them being the tumor stage, meaning if the tumor is localized or spread at the time of diagnosis. It's highly dependent on the pre and postmenopausal status of the patient. And it's highly dependent on the molecular profile this tumor has when it's biopsy and further studied in pathology. As per treatments, almost always breast cancer is gonna involve some type of surgery and radiation. The surgeries can be lumpectomies, all the way to mastectomy with breast reconstruction surgery. We're going to talk about hormonal therapy, but there's also other choices like systemic chemotherapy when the disease is very spread at the time of diagnosis. And there's also a last choice of immunotherapy, which is relatively new. It was approved by the FDA around 2017, and it has been shown very good tolerance among patients with less side effects. Okay. So as I said, I'm going to focus on the hormonal aspect of therapy. This is important because the molecular profile of the tumor basically gives us a specific target, and that way we can attack cancer in a more specific way. The receptors that are in these tumors can be estrogen, progesterone, and HER2 receptors. Okay. So just for completion's sakes, we are going to talk about aromatase inhibitors in the hormonal domain of the treatments. Aromatase inhibitors, basically their action is just inhibiting the aromatase enzyme, therefore less estrogen availability is in the body for the tumor. It depletes the estrogen, basically cutting off the nutrition supply, we can say, of the tumor. Therefore, the tumor will start to shrink and be more treatable for surgery. So yeah, so all this served as basically as an introduction for us to talk about the trial that I wanted to share with you guys today. Is called the MA17R trial, and it was published in 2016. I got a little bit more information about that on the next slide. Yes, is double-blinded randomized placebo-controlled trial. It was done by the American Breast Cancer Group and the Canadian Cancer Trial groups together. And the primary endpoint or the objective of this trial was to assess the disease-free survival of postmenopausal patients if the adjuvant therapy inhibitor was continued for an additional 5 years. So to give you a little bit of background, patients with hormonal positive breast cancer receive either tamoxifen or an aromatase inhibitor as an upfront therapy. And this trial wanted to assess when these patients are free, if you add an additional 5 years, how much the disease recurrence would be reduced, basically. Disease-free survival, you're good, was defined by them as the time from randomization of the patients to the possible recurrence of the breast cancer. So just a little bit of concepts, adjuvant therapy as per the NCI, it's defined as an additional treatment after the primary treatment was already given to reduce the cancer recurrence. This serves as like the main concept when we talked about an aromatase inhibitor in this specific study. Okay, some other important concepts before we dive into the results of the study and how they did it. So overall survival rate is the percentage of patients in the study who are still alive for a certain period of after they were diagnosed or started treatment. And the hazard ratio basically was used in this study to determine if there was a significant difference between the two groups. And I pointed out these concepts because in the study, they will refer to overall survival rate and how it affected during the study. Okay, so like the trial breakdown, we already talked about the endpoint or the objectives. We are gonna talk about methods, how are these patients were, how are they assessed, and their discussions. So methods, as I mentioned earlier, is a double-blinded placebo-controlled trial. They wanted to assess the effects of extending the aromatase inhibitor, specifically letrozole, for an additional 5 years. A total of 1,918 postmenopausal women who had already primary breast cancer and had already received an average of 5 years of treatment, either with aromatase inhibitor or tamoxifen. Those were this study. And basically what they did is they gave 2.5 milligrams of letrozole to one group and placebo to the other group for the following 5 years. So the eligibility criteria of these patients, they needed to be disease-free. They were disease-free and had already completed, as I mentioned, 5 years, around average of 5 years of prior treatment, either with an aromatase inhibitor or tamoxifen. For obvious reasons, they needed to have a hormone receptor positive primary tumor. These patients needed to have a performance status of less than 3. So basically, performance status is how these patients, how they're affected by the disease. Basically, they use the scale called the Eastern Cooperative Oncology Group Scale. It's a 5-point scale that assessed the disease-related disability of these patients. And the higher the number they had on this scale, the more they had disease-related disability. So these patients needed to have a score of less than 3, meaning that these patients were able to perform self-care, were able to ambulate, but they were confined to a bed or a chair for around more than 50% of their time during the day. And of course, they have to have a minimum life expectancy of at least 5 years to basically see the complete time of the trial. Thank you. So assessments, were these patients assessed? They were assessed annually, and at each visit, these patients were assessed for disease recurrence. So they underwent mammogram studies. They were assessed for one of the most common adverse effects of the treatments, which was osteoporosis and bone fractures. They were also assessed for adverse effects and how was their quality of life. And they used two scales, the NCI Common Toxicity Criteria. It's basically a scale that assesses the severity of adverse effects, and they used this criteria. Grade 1 was asymptomatic mild symptoms versus 5 or 4, which is life-threatening symptoms. And yeah, the adherence of these patients was confirmed verbally at each visit. Okay, so in terms of results, what did they find out? The primary objective of this study was the disease-free survival in those 5 years. And it showed that in the letrozole group was a 95% disease-free survival in comparison to the placebo group with a 91% disease-free survival. 4%, right? Not too much, you could say, but in a couple of slides after, we will see how much it impacted the guidelines they use today in treatment. To go a little bit more in detail, there were around 165 patients overall that had disease recurrence. Of those, 63 patients were in the letrozole group, and 98 patients were from the placebo group. And in terms of contralateral breast cancer recurrence, 13 were in the letrozole group and 31 patients in the placebo group. And you can see basically in every criteria, the recurrence was higher in the patients who received placebo versus the letrozole. Next slide, please. Yes. So this was the point that I wanted to. Even though the disease recurrence was reduced in the patients that received letrozole, they noticed that the overall survival between the both groups was the same. So even though it helped this decrease the disease recurrence, how long these patients lived basically was equal in both, with in the letrozole group versus a 94% in the placebo group. Yes. So this graph basically it showed when they took basically the incidence alone per year as the years progressed. You can see again, placebo group 31 events versus letrozole group 13 events reported. So a significant impact in patients who received the aromatase inhibitor. Now moving forward, results, but in terms of adverse events. So adverse events were similar in both groups. However, there was a distinct adverse event that was different or more noticeable in both of them, which related adverse events. Specifically bone fractures. We can see that patients in the letrozole group were 133 who reported bone fractures versus 88 in the placebo group, exactly. Whereas new onset osteoporosis on patients on letrozole was 109 versus 54 in the placebo group. So even though it was adverse event, it was a event that they said it was expected, given these patients were receiving basically medication to deplete estrogen in the body. However, a good point to highlight is that both groups, even though these results show that the letrozole group had more of it adverse events, were in vitamin D and calcium supplementation for the entire trial. Some limitations of this study, it was the verbal confirmation of adherence. However, they reported around 62% of adherence in both groups. Another limitation was pre-selected population. So as I stated at the beginning, the MA17R trial, R standardization, because the MA is a follow-up trial from a previous one. So it could be a limitation because the patients that were already participating in the study were in tamoxifen and aromatase inhibitor in the years prior. So discussion, they said estrogen receptor positive breast cancers that carries high risk recurrence despite the 5 years of adjuvant therapy, and that their trial showed statistically higher disease-free survival in women who receive letrozole, independently to their nodal status. The risk of disease and contralateral breast cancer was reduced in 38% in women who received letrozole. And they also stated that there were no overall survival differences between the both groups. On the next slide, yes. So as a final point, I wanted to show you guys this. These are the guidelines from the American Society of Clinical Oncology. These guidelines were updated in 2018. And if you go to the next slide, yes, these guidelines were updated in 2018 using as evidence the MA17R trial, in addition with all these trials, the NSAP, the DATA, the IDEAL trial, the EP trial, and the SOUL trial, all of them served as evidence to sufficient evidence for them to update their guidelines. So now they recommend women, even with no negative cancer, to be offered the extended treatment for an additional 5 years, 10 years in total. They recommended also that node positive breast cancer of the additional 5 years for a 10-year total. However, the total treatment cannot exceed the 10 years of. And finally, they recommended that the decision of starting the patient on the additional 5 years must be considering the benefit, adverse effects of the patients, the risk factors being like age or family history. And yeah, that's the last slide. Yes.
Jen, I think somebody raised their hand and potentially had a
Oh,
question, unless that was an accident. Dana, did you have a question?
Oh, no.
Oh, okay. I saw the
but
hand raised.
no, you're good. I believe that's the finale of the presentation. I want to give you guys thank you for like letting me talk about this and like having the air. It makes me very happy to like share this and spread awareness, and hopefully a little bit of insight of breast cancer. And if you guys have any questions, feel free to ask me.
Thank you so much, Jen, and very fitting topic for this month. Does anybody have questions for Jen? No questions.
I just wanted to do a clarification. Can we go back to, and first of all, congratulations, Jan. It was a great presentation. I just want to go to where it was all the statistics at the beginning about how breast cancer was the most common. Back.
That one.
That one. So I just want to clarify because it is an NBME question. Yes, breast cancer is the most common diagnosed cancer in women, but I think it's the second leading cause of death in cancer in women. The first one will be lung. I just made the clarification because, like I said, it's an NBME question.
Yes.
And it comes up in the step 2.
Thank you so much. I should review that for sure and change it.
Yeah.
Thank you.
Yeah, good point, Marcos. Any other questions or comments?
So I do have a question.
Go ahead, Julia.
Okay, so in the MA17 trial, so according to the NCCN guidelines, which is also where you can find most of, since you're interested in oncology, it's very good
Mhm.
summary of all new guidelines for every single type of cancer you can think of. It's free, you can sign up for it.
Wow.
So the extended aromatase inhibitor therapy, is it just used in postmenopausal women with hormone receptor positive breast cancer, or was it also used in premenopausal? Because I just wanted to clarify that. I'm not sure if you know
Yes,
that.
excellent question. It is used on postmenopausal, given the study, since the study included postmenopausal patients, the recommendations were only for postmenopausal women, basically. Yes.
Okay, and then a follow-up is you mentioned some of the adverse effects of bone loss,
Mhm.
etc. We know that is kind of the side effect of the drugs that they're using in the study. Did they mention how they overcame this, or for example, did the women have to undergo annual like DEXA scans, or are they just started on like vitamin D and like bisphosphonates the second they start the extended therapy?
Do you refer during the trial?
Yeah, was it mentioned because because you
Yes.
mentioned that the trial had adverse effects of bone loss, for example, in
Yes.
women compared to the placebo group. So I wanted to see if the trial actually addressed how
Yes.
that could be overcome. Like, because I know it's standard practice. Like, if you give women endocrine
Mhm.
therapy, you have to give them vitamin D and
Yes, they were.
bisphosphonates.
They were
Okay.
at each, so they had, every patient had an annual assessment, and in that assessment, they had a DEXA scans
Right.
regarding the
Okay.
trial, and I don't have the exact doses, but both groups were with calcium and vitamin D supplementation. Thank you for the questions. Very good questions.
There was another question, wasn't there? Weren't two of you trying to talk at the same time?
I was gonna mention something. I was gonna ask about the graphs slide where it talked about the disease-free survival and overall survival. Yes, that one. If they mentioned anything about, so it was just interesting that overall survival. So yes, the disease-free period. So it showed that the drug was beneficial with the additional 5 years. But the overall
Yes.
survival, they mentioned like what were the other causes why there was no difference between overall survival, if it was just other health
Yeah.
factors or
Yes.
comorbidities or whatnot.
For what I can recall of the paper, they did mention cancer, other types of cancer in the patients, and heart disease. They pointed out these two conditions that probably the cause of the known difference in the overall survival.
Okay, thank you.
Thanks.
I just shared a link Julia sent to me because, sorry guys, I still haven't figured out how to change the settings so that everyone can message the whole meeting chat. Julia, do you want to mention what the link is? Is it just what you were mentioning?
So it's basically National Comprehension Cancer Network for Oncology Research, and it's way easier to look up if you are like questioning next best step of management of some cancer. They'll give you like the algorithm, and it's based off of the most updated research. So instead of you sitting there and reading thousands of papers trying to figure out which one is new and which one's actually approved, this gives you a good summary. And I had no idea about it until the oncology cardiothoracic surgeon came in and was like, this is something I wish I knew about as a medical student, because then it just makes my life easier because it's just all summarized and it's every single type of cancer. It's all there.
That is so clutch, honestly. Thank you so much.
Yeah, exactly. I was like so amazed. And they also have an app as well, like it comes in handy and it's free. So we like
Oh.
free things as medical students.
We always like free things. Okay. I kind of had a question. So Jen, you were mentioning, I think it was on this slide, that okay, they shouldn't receive more than 10 years of the treatment. Did you mention why that is? Is it just because of the side effects? It's not worth the risk.
So I believe they recommended that because the MA17R trial was the study of an additional 5 years. And all of these patients had been previously aromatase inhibitor 5 years. So it was a 10-year total treatment like span. That's why they didn't recommend more than 10, because they haven't studied the benefits or no benefits of an additional 5 years.
Oh, okay, okay, makes sense. Thank
Yeah.
you. Any other questions, friends, or should we move on to our general meeting?
I don't have a question, but because my attending is a breast surgeon, since she always quotes this other trial, it's called the Z11 trial, and it's kind of a similar study where it's kind of what it did was basically, so the MA17 trial basically changed guidelines for endocrine therapy, so more like drug wise, versus the Z11 trial kind of changed surgical intervention management of breast cancer. So it's more, how would you treat axillary lymph node dissection? Do you do it immediately versus do you do sentinel node first and you do this? And there's like specific criteria. I think it's a fun read. She always quotes it, and it's a UWorld thing that they kind of just assume that you know the trial, but it kind of, if you read it, you'll understand why sometimes the answer is, oh, lumpectomy with sentinel lymph node first, and then you can do like axillary, and then why sometimes you would need to do a modified mastectomy with axillary lymph node. Like it just like it kind of explains it kind of thing. But that's just for people who want to go into surgery. If you want to do that, then that's a good trial to read as well.
Sorry, can you
was
mention the
that?
name of the trial again?
Yeah.
Yeah, it's called the Z11. So Z0011 trial. It's basically like it demonstrated sentinel lymph node dissection alone. It was non-inferior to axillary lymph node dissection in terms of like overall survival for patients that meet the criteria for those. So it's basically saying you don't need to do an axillary lymph node dissection in every single woman with breast cancer, because we know axillary lymph node dissection kind of has more complications with your lymphedema and then you can get like the infection of your lymph nodes and all of that stuff. So that's also a big how do I want to phrase this? It's like it was one of those trials as well that was that kind of modified management of breast cancer. I don't know, my breast surgeon is obsessed with it. Every time we get a question, she's like, yeah, according to the Z trial, this is what you're supposed to do. I'm like, okay, let me read it.
Is that the one, Julia? I just Danielle sent it in the chat and I clicked on it. Did you see where I was? Is that it?
Yeah, that's basically it. The Z11. Yep.
Okay, cool. Well, I put in the chat for all you guys to have access.
Thank you.
All right, cool. Thank you for all the insight, Julia. And honestly, guys, if like maybe next time that's on us. Next time we'll like ask the whole group if anyone knows anyone who can come to the meeting, because that would have been such a valuable person to have at this journal club.
Yeah, she would have loved, because she's going to retire in 2 months, and she's the attending that I was talking about the other. I mean, you were not there, but I mean, actually, you were there, Samantha. The attending that comes in every day and does like UL questions and AMBOSS questions with the students. So when I go
Oh.
home, I don't feel bad for not studying. She's like very big on teaching, and she loves teaching for some
Oh, I
reason.
love that. Yeah, let's
Yeah.
keep her in mind for the next one.
Okay.
But if nothing else, then we'll say thank you one more time to Jen. Hold on, there's something in the chat.
That was me.
Oh, okay.
It's
Oh, you
just
can look at it.
yeah,
Nice.
a summary of AMBUS, what I said, of the breast cancer mortality rates in both women and male.
Thank you. Okay, I'm gonna stop the recording. If this thing pops up, give me 1 second. There we go.